Hi everyone, we're going to talk about alterations in respiratory system function. Here's your objectives. I do want to say that I think it's really important in here that you understand what these medical conditions are. You probably don't need to know the super deep, dark pathophys, but you need to understand it well enough that when we talk about using particular drugs for the particular disease, that you understand why that drug is effective in treating the disease or treating the symptoms of the disease. And then again, anytime we talk about meds, we're going to want you to know, their mechanism of action, their indications, side effects, adverse effects, including even contraindications, reasons why the patient should not take the medication, and then the nursing considerations. Because remember, we don't just give medications, because they're ordered. We give them because we have an understanding of what they do for our patient and we have an understanding of what we need to monitor while the patient's on that medication. So I want you to just think about this for a minute. Maybe stop yourself, stop the recording, and just think a little bit about the respiratory system. And go from the nares, which is the openings of the nose and the mouth, all the way down to the lungs, and how we get oxygen from our environment into our bodies and into our tissues. It really is quite amazing. Okay, so let's review the respiratory system. We have an upper respiratory system and a lower respiratory system. And so those are referred to frequently when we talk about, if you have symptoms of an upper respiratory tract infection, then you're going to talk about things like sinus pressure and sore throat and nasal drainage, versus lower respiratory tract is pretty much lungs, right? Okay, so the primary function is gas exchange. You know that. We've already studied that. And so we provide oxygen for metabolism in the tissues and remove carbon dioxide, which is a waste product. So that's a three-step process. We have to get air in and out of the lungs, right? That's ventilation. That's breathing in and breathing out. Diffusion, which is that transfer of oxygen between the lungs and the blood. And then perfusion is to move the blood from the lung capillary out to the tissues of the rest of the body. It's the oxygen in your lungs somehow has to reach your toes. And so that's what perfusion is. So let's just review some A and P. So you have the lungs, you have the diaphragm, and then the diaphragm separates the lungs from the abdominal cavity. You have a visceral pleura. That's a membrane that covers the lungs. It's like the sac that the lungs are in, okay? Then you have the parietal pleura, which is the membrane that lines the thoracic cavity. That's the muscular, cavity that your lungs sit inside. And then the space between those two is called the pleural space. And again, this is the space that has some lubricating fluid in it, so that your lungs, as they breathe in and out, can have some lubrication. Otherwise, we'd have friction in there and there would be a rub, and that would not be good. So looking at the lower airway, we have the trachea or the carina, right? And then we have the bronchi. So the trachea bifurcates into two main stems. And you can see that here on this drawing. It goes this way and it goes this way. It just happens that this bifurcation then quickly bifurcates again. So you have the bronchi, right, which are these big tubes that lead out to the bronchioles, and then respiratory bronchioles to the alveoli. There's an epithelial lining inside, and that epithelial lining has some exocrine glands in it. And remember, exocrine glands are glands that excrete versus endocrine glands, which are glands that exocrine tends to be outside the body or into an outer cavity, like sweat, right? That's an exocrine gland. Whereas endocrine are inside the body and are inside usually an organ and are going to release a hormone right into the bloodstream. So exocrine glands that we are focusing on here are the goblet cells, which make mucus and create this mucus blanket that is all, it lines our epithelium here and all inside our bronchi. And then we have ciliated cells, which are little hairs right on the cells, and you can see them here, right, that move this mucus layer to places it needs to go. And think about when you're really sick and you've had a bad chest cold and you cough and you get all this guck that comes up that's sometimes a yucky color. That's being facilitated by your ciliated cells. And then you have the alveoli, and this is really where the work of the lung is done. It's kind of the point of true action. This is the site of carbon dioxide and oxygen exchange. We have 3 million of these as an adult, which is amazing. So we have some different cells in here, type 1 and type 2. I don't know that you need to know that, but our type 2 cells secrete surfactant, and that surfactant helps keeps our lungs expanded rather than collapsing on each other. And it's produced around the 26th or 27th week of gestation. So you may have experienced in your maternity clinicals that if a baby looks like it's going to be birthed prematurely before 37 to 40 weeks, that we give some medications that help sort of deal with the fact that there isn't much surfactant here. And then we have macrophages, and macrophages are these big immune cells that function to remove foreign material through our lymph node system. So very important. And you think about it, our lungs, we're breathing in lots of stuff. We're breathing in the environmental toxins, dust, allergens, things like that, bacteria, viruses, fungi. And so these macrophages are critically important to maintaining our everyday health. Okay, so let's talk about the pulmonary circulation. This, again, is what provides for gas exchange, O2, CO2, and it delivers nutrients to the lung tissue itself. Because remember, the lung tissue itself also needs oxygen, also needs nutrients and things to stay healthy. The lungs also act a little bit, the circulation of the lungs acts a little bit as a reservoir for the left ventricle, because remember, everything that is coming from the left ventricle or from the lungs is going to go back into the left ventricle. The pulmonary artery divides into arterioles and then into capillaries. And one of the things that makes this all work is that our systemic circulation, just our general circulation out in our bodies, arms, legs, whatever, has a certain pressure to it. In the lungs, it's lower, which really facilitates that infusion of blood into those vessels and arteries. And then there's alveolar capillary membrane, a thin membrane where the gas exchange actually occurs. So you can see that really nice picture here of how the capillaries, out the venous and arterial capillaries, kind of cluster around each alveoli for this gas exchange procedure. And then the pulmonary vein, drains the capillaries, and in an odd, way, then the pulmonary vein takes everything to the left ventricle. Okay, so just to review, hemoglobin carries 98 to 99% oxygen in the blood, and that gives us about a 95 to 97% arterial saturation and a 70 to 75% venous saturation. When we're using an O2 sat monitor in the hospital, we're measuring arterial saturation. And then in the lungs, oxygen moves across that alveolar capillary membrane, binds with hemoglobin, and then it's carried out to, wherever it's going to be used. And then oxygen is dissociated from the hemoglobin, kind of like undocking, and is able to be used by the cells. So let's review CO2 transport. So it's transported in 3 ways. One, it's dissolved in the plasma as the PCO2. We've already talked about that a little bit as we talked about blood gases. It's attached to the hemoglobin, 30% of it as carbonic acid. And then the rest of it becomes bicarbonate, right? And that's about 60%. So CO2 is more soluble than O2 and diffuses really quickly into the blood from the cells, which is good because we need to get it out of the cells, right? And again, CO2 is formed by metabolism. So, and then it's released from the hemoglobin back to the lungs. It's like this little exchange that occurs with the hemoglobin. And so pretty elegant system there. So again, this is just another really nice picture up close of how CO2 and O2 change places and diffuse across, the respiratory membrane of the alveoli. Okay, so ventilation. This is breathing, basically. So movement of air in and out of the lungs, right? That's what we think of as breathing. Respiration is the exchange of oxygen and CO2 during cellular metabolism. Don't worry too much about the difference between the two of those. Respiratory rate is actually the ventilatory rate. So how often we're breathing in and out, a cycle in, out in a minute. The tidal volume of air is the amount of air per breath. So it's truly like if we were to exchange air for water and take a deep breath, that would be our tidal volume. And it's 400 to 800 mils. So things that affect tidal volume, like chest restrictions, pneumothorax, things like that, are really going to impact ventilation. So minute ventilation is respiratory rate times tidal volume, and it's expressed in liters per minute. And so that's where that sort of relates a little bit to our, again, our flow rate of oxygen. We think about that from the wall, right? Is liters per minute coming out of that tubing and out of, the nasal prongs or mask or whatever. Okay. So ABGs really are the determiner of whether ventilation is going well or not. So successful ventilation involves several things. It's not just having the presence of air or, or alveoli that work. It has to do with, it's a really complex system, in that you have to have muscles of inspiration and expiration. You have to have alveoli that have good surface tension. The elastic properties of the lungs and the chest wall, right? So how pliable is that lung tissue? And then resistance to airflow. And then compliance, again, is that, ease of lung expansion in and out. And when you have things like, again, muscle diseases or other injuries or things that cause, that impede that compliance piece, you're going to have issues. Even compliance is affected by emphysema. And then elastic recoil, ability of the lungs and chest wall to return to their resting state after inspiration. So it's one thing to fill up with air, but those lungs also have to go back to their resting state. And so again, if you have a disease that's causing sort of a brittleness or a non-compliance in those lungs, it's really going to affect ventilation ability. Now we're going to talk about respiratory control centers, because the vast majority of these are in the brain. And so, breathing is all controlled by the nervous system because it's involuntary, right? It's part of our involuntary nervous system. We don't have to sit and think about breathing. And the brainstem is what controls respirations. That's why if somebody has a brainstem injury or a brainstem tumor, it's usually fatal, because our lungs don't know to breathe on their own. They're breathing because our brain is telling them to breathe. So how does our brainstem control respirations? It gets input from central and peripheral chemoreceptors that then transmit impulses to respiratory muscles, causing them to contract or relax. The pattern of breathing, however, can be influenced by emotion, pain, disease, and we actually can exert a fair amount of control over our breathing, which, if you think about it, we do things like yoga, deep breathing exercises, relaxation. Yeah, so we do have some control over all of that. Okay, onward. So, the central chemoreceptors, again, this is more of just sort of an interesting piece of information. This isn't something that I would expect you to know deeply, but CO2 diffuses across the blood-brain barrier, which makes sense, and stimulates our respiratory center, right? And then from there, that activates certain chemoreceptors. Respiratory center increases the depth and frequency of ventilation, and increased ventilation eliminates more CO2. If you think about Kussmaul breathing that we talk about with diabetes, this is a great example, right? This is how our body is saying, wow, DKA, we're acidotic, increased, which is caused by increased CO2. And this is what stimulates our brain to go in and say to the lungs, hey, you got to blow off some of this CO2. We're way too acidotic in here. So what do you think are special respiratory conditions for the elderly and for small children? So just pause for a minute and think about what those might be. So for the elderly, they have decreased compliance, and that just comes with age. Musculoskeletal changes, we don't have as much muscle mass as we get older. Even skeletal wise, we have, decreased calcium. Our bones become more brittle. Elastic recoil diminishes. Pulmonary capillary flow decreases. Our alveoli dilate in an attempt to compensate for this pulmonary capillary flow decrease. So surface area decreases even though the alveoli the alveoli dilate, we still don't have any more vessels, right, to cover that area. Respiratory center sensitivity for hypoxia or hypercapnia being high CO2 and hypoxia being low O2, it decreases. Again, brains don't function as well as they get older. It's something for you all to look forward to. Your immune system response decreases, and then changes in activity and fitness cause decreased respiratory muscle strength and endurance. When you see these programs like Silver Sneakers or other things, and you see folks who are, older, but they're like riding a stationary bike or they're trying to do some weightlifting, those things help immensely in maintaining some of the muscle that they have, and helping with their lung capacity. So there's a lot of sense to being an exerciser even as you get older. All right, so I'll let you do this matching. Here's the actual answers, so that you understand these concepts. One of the things I want to point out is we talk about recoil. Recoil is one of those things that we talk about in CPR, right? If we don't allow the chest to recoil, meaning to re-expand, we don't give it an opportunity to fully re-expand, we really diminish the amount of ventilation that's occurring, and therefore oxygenation to blood. So we want there to be recoil when we're doing CPR, so that we're not just, it's kind of like squishing a ball and then not releasing it very much and squishing it more, squishing it over and over again. You want to totally release it, squish it again, totally release it, squish it again. Sorry, that's kind of a weird analogy, but since we've all done CPR, maybe it helps a little. Okay, so see if you can tell the difference between hypoxia and hypoxemia. Remember, hypoxia is out in the tissues and hypoxemia is in the blood. So these are pretty closely related. So hypoxemia, emia is blood, hypo is low, ox is oxygen, right? So SaO2 is less than 90%. And so how does this happen, hypoxemia? Well, it could be that just the oxygen being delivered to the alveoli is less. That happens when we get up into high altitudes. Or diffusion of oxygen from the alveoli to the blood is impaired in some way. So that could be like hypoventilation or a VQ ratio mismatch, where the the alveolar capillary membrane is somehow impaired. And actually, a great example of this is COVID, where we found that the alveolar capillary membrane and the alveoli, sorry, not the alveoli, the capillaries were actually infarcted. They were actually, on autopsy, they could see in there that it's almost like clotting up all of those little capillaries. And so if they're clotted, there's no amount of ventilation from a ventilator that's going to help that, right? And there's no amount of, giving them a blood transfusion or anything like that. So because the problem is where the blood is supposed to pick up oxygen, that blood it's infarcted, again, clotted off. So so very interesting. So when this happens and a patient becomes hypoxemic, they're going to have some clinical manifestations. They're going to be activating, unconsciously, of course, compensatory mechanisms like breathing harder, breathing faster. Maybe there's blood shunting occurring from the periphery toward the lungs, brain, heart. And so you see, you see some issues there out in the tissues. Here, in terms of VQ ratio, I don't expect you to know this ratio. I don't think that it's something that as a beginning nurse you really need to know, but I think you do need to understand the concept. And so blood flow and ventilation of the alveoli is never perfectly matched. I would say that is a key concept. And perfusion is somewhat greater than ventilation. So it's sort of like if we can get oxygen down there to the to the alveolar membrane, we want to make sure that there's enough blood. So there's more blood than there is oxygen. That's okay, actually. But when ventilation and perfusion are matched, then unoxygenated blood mixes with oxygenated blood, changing the VQ ratio, and you can get hypoxemia. Again, know the overall concept. Don't get caught up in the specific language of this. So a VQ mismatch is, if it's low, that means there's not enough ventilation, low ventilation, to oxygenate the blood, right? And here's some conditions that might lead to that, like pneumonia or atelectasis, asthma, pulmonary edema, pneumonia, versus high VQ where blood flow is less than ventilation. And a great example of this is pulmonary embolism. Pulmonary embolism is, again, where you're going to have an infarct or a clot in that pulmonary vascular system. And so now there's no blood to come and pick up the oxygen that's in the lungs, and the blood leaving is unoxygenated, and that's incompatible with life. About 30% of people who have pulmonary embolism will die from that condition acutely. They'll die in the moment or in the moments following it. So other things that lead to hypoxemia can be sort of, the alveolar capillary membrane exchange center, right? So if you have fibrosis or edema, destruction of the alveoli, then you're going to end up having problems. If you have decreased surface area, I mean, we could have hypoxemia, just somebody who ended up having maybe a piece of their lung removed or having a lung removed. Usually the body is pretty good at compensating for that, and the other lung will develop the capacity to deal with that, but that can be a problem. That's why we can't, cut out 3/4 of someone's lungs and still have them be able to survive. And then, of course, acute respiratory failure, which could be due to a number of causes, and that leads to, right, a PaO2 of less than 60 and a PCO2 of greater than 50, which we've already learned about this semester. So if you're unclear about this, you might want to just go back and review it a little bit. Wow, here's a picture for you, but it's actually really, it's a good one. I'm sorry, it's cut off a little bit. But here's some problems with hypoxia. So hypoxia, again, is where you have not enough oxygen in the tissues. So here's some of the things that you can, that you can see as a result of that. One of the things that you'll see as a result of chronic hypoxia is some of these signs and symptoms that may be over here. So early on, you'll see restlessness, tachycardia, tachypnea, dyspnea. Those are all, tachycardia and tachypnea are compensatory mechanisms, right? Your heart and lungs are like, oh, okay, I'm not getting enough oxygen. I'm going to breathe faster. My heart's going to beat quicker. I'm going to try to get more blood to those lungs to pick up oxygen. But it causes other things like agitation, anxiety, diaphoresis, which is sweating, retractions, which is where you see the skin between the ribs or around the clavicles, really pulling back so that you can see those, those spaces are kind of more fully defined. You can have a headache, altered LOC. In little kids, you'll see things like nares, flaring, grunting, stridor, feeding problems, because feeding requires a lot of it requires a lot of oxygen and a lot of effort. So feeding to a baby or an infant is sort of like, jogging for a teen, and it does require effort. And so, yeah, it can really end up causing major problems. But remember, hypoxia is the cell tissues more than hypoxemia, which is not enough oxygen in the blood. But one leads to the other for sure. Hypoxemia will definitely lead to hypoxia. They're tied together. So signs and symptoms of pulmonary disease: dyspnea, right? Hard time breathing, increased work of breathing. You can tell increased work of breathing is someone who's using all of their accessory muscles. They're tripoding. They really have a hard time breathing when they're laying down. They may have nasal flaring where their nares actually open up a little bit. That's an attempt to sort of bring in even more oxygen with each respiration. I know for asthma, I used to watch my kids' retractions, and the higher the retractions get, the more distress the patient is in. So low retractions indicate something going on down deep in the lungs, but the higher the retractions get, the higher the symptoms get. And I'll tell you what I mean by that. The worse the oxygenation situation is. So I'll tell you, in infants and children, and actually you can hear it in adults too, is they'll begin to grunt when breathing's really tough. So you hear them go, uh, uh, That's an opportunity for them to try to hold oxygen into their lungs, increase that that oxygen exchange. And like I said, nasal flaring. And once you see, especially in children, you'll see that what happens with kids is they do great, they do great, they do great, and then all of a sudden they just poop out. They have these wonderful, beautiful compensatory mechanisms that keep them just trucking along. And it's kind of like all of a sudden they just fall off the cliff. Versus adults, you can kind of watch their respiratory effort, oxygen sat go down over time. So the reason that we worry about this in kids is when we start seeing things like grunting, flaring, decreased level of consciousness or tiredness, inability to talk if they're a talking child, which if they're an infant, they're not. We start worrying about a child beginning to run out of steam and energy for breathing, and that they're getting closer to respiratory failure, which is scary. Again, signs and symptoms of pulmonary disease: cough, right? So we all know what cough is, and we know that acute cough, right, can last for anywhere from 2 to 3 weeks. You can have rhinitis, which is a runny nose with it, bronchitis, pneumonia. Rhinitis makes us cough because it postnasal drip runs down the back of our throat, and that triggers some of our coughing receptors. Chronic cough is like, it's persistent. It doesn't really go away. And it's something that, if you know someone with a chronic cough, you know what I'm talking about. Asthmatics can have this, especially if they're poorly controlled. And people with gastroesophageal reflux disease, so GERD, can have this as well, where there's just this constant stimulation to cough. And if you think about asthma, in asthma, we have bronchoconstriction combined with mucus production. And so the body's working all the time to try to get that out of there. Antitussives, we talked about this. I think the one that I had you memorize is codeine. Now, codeine is also an opioid, right? So it can be used for pain like Tylenol number 3, if you've heard about something like that. But in and of itself, it's a really great antitussive. And a lot of times you'll see it paired with like Robitussin. So it'll be like Robitussin with codeine. And then Benylin is a non-opioid and it's less effective. But these drugs work by telling your cough center in your brain to not cough. And it's really good for coughs that are non-productive, irritating, or that are causing such exhaustion that your patient can't function. And so we have to really weigh, again, sort of the pluses and minuses of giving an antitussive. And, it's one of the things that you could advocate for your patient, because if you're in the hospital or even in a clinic, physician may come in for, 5 minutes or so. And if the patient is coughing during that time, they may not, recognize that this is an issue. So you as the nurse, talking about what's your night like, how much is this impacting your, activities of daily living. You may be able to say, hey, like this person talks on the phone all day long in their job and they just can't, they can't function. So side effects of these drugs are dizziness, drowsiness, sedation. Well, that all makes sense because it's an opioid. GI irritation, nausea, probably not so much of that. Dry mouth, constipation. Again, constipation and respiratory depression have to do with the opioid just sort of shutting the body down a little bit. You can give with food or milk. Now, there's some contradiction out there about milk and whether it causes more mucus production. So if the person has a mucus problem, I'd probably give it with food and not give it with milk. And then it should just be taken short term. Like, again, a lot of times just sort of turning that cough center off for a while can be enough to kind of get the patient past this chronic cough or this acute cough. Change positions gradually, increase fluid and dietary fiber since they're taking an opioid. So just make sure that, while we're fixing one problem, we don't cause another. And then contraindications are people with liver or renal disease, alcoholism, head trauma, St. John's wort. That should be wort, W-O-R-T, because they can cause increased sedation. Now, expectorants, these are very interesting, and we're seeing the use of them a lot more. I'm a big believer in guaifenesin and use it when I get sick. Actually, sometimes I'll even use it when my asthma is acting up because it does thin, thick mucus. And so it can loosen bronchial secretions, which is great because then it can help, get them up. It is used for dry, unproductive cough and to stimulate bronchial secretions. I personally recommend it with a cold. But you also have to take a lot of water when you're taking it as well, because it is relying on thinning out secretions. So it's relying on having water to work. And so it can cause dizziness, drowsiness, GI distress. You shouldn't be taking it all the time. So this shouldn't be something that someone takes all the time. It should only be taken kind of for an acute problem. And then you should not take this drug if you're on ACE inhibitors or you have CHF. And again, guaifenesin inhibits platelet function, increases the risk of hemorrhage with heparin therapy. So you have to be really careful. We don't think about that. Something that, is used for cough would actually affect our platelets. But again, and it inhibits platelet function, not in that it reduces platelets, but that it makes the platelets themselves not very adherent, makes them kind of slippery so that they don't stay well when you're trying to build the wall with the bricks and mortar. The bricks are slimy. Okay. Okay, a mucolytic. Now, a mucolytic is different from an expectorant in that an expectorant just thins the mucus, which helps it, come out easier. This actually breaks the bonds inside the mucus and actually thins it out by sort of, lysing that mucus and destroying it, breaking it down. So that's very, very different. But, in some ways, it, it works the same way as an expectorant, in that ultimately what you want is to break down the mucus, thin the mucus so that it will come out. But there is a difference between a mucolytic and an expectorant. So you need to know that. So you want to listen to lung sounds. If you're giving a subtle cysteine mucomist, it's given as an inhaler or a nebulizer, and it smells awful. It smells like rotten eggs, super gross. So it's not something that we use on the regular, but it is something that can be used, for somebody who really is having respiratory issues, and we're trying everything possible to help them. So you want them to be well hydrated, and you want them to take some deep breaths and cough, because again, you're breaking up that mucus and you want to get it up and out. So how do we know somebody has pulmonary disease? I mean, like, what brings somebody in for asthma or other things? It's these things that we see, right? Abnormal sputum, hemoptysis, which is bloody secretion, so they cough, and what they cough has blood in it. Abnormal breathing patterns, so a low respiratory rate or high respiratory rate, or increased respiratory effort. My kids had asthma, and I could see them, I could hear them wheezing, and I could see them wanting to sit up, lean forward. It's hard for them to breathe. Small respirations, again, are specific to metabolic acidosis. And you have an increased rate of breathing along with a large tidal volume and no expiratory pause. So you're going to get a lot of blowing off of CO2. And then Cheyne-Stokes, this happens usually toward end of life. And it's alternating deep and shallow breathing along with periods of apnea. And it usually is related to reduced blood flow to the respiratory center of the brain. So here's some examples of different types of breathing. You don't need to know about Biot's respiration, but just if you need a visual to help you see how these work. This is a really good one for Cheyne-Stokes. And it helps you as a nurse know that you're getting closer to the end in terms of, educating families and providing for comfort measures. Cyanosis. So cyanosis is something that we see when there's not enough oxygen. It's caused by desaturated hemoglobin, meaning desaturated, not enough oxygen on the hemoglobin. So you want to look at things like lips, nail beds, ears, cheeks. Peripheral cyanosis is like blue fingers or blue toes. You're looking at nail beds. And then central cyanosis is something that you see more like the buccal mucous membranes of the lips. You may even see on an infant or child, like where they have kind of a blue trunk. And it's always scary. And here's my take home for you about blue. Blue equals dew, meaning if you see cyanosis and you decide, okay, well, I always assess first. Well, guess what? You just did your assessment. Blue is part of an assessment, right? It is noticing the color of something. Sorry, that's my doggy. And then the other thing that happens is you don't need to listen at this point. You might need to listen to lung sounds to see what's going on. But, if you throw on like an O2 sat monitor, that might help you in terms of your treatment decision and what you're going to do next. But it is, you don't need to not do something before you get an O2 sat. I mean, somebody who's blue has major major issues. So you need to look at that. Now, there are some conditions where somebody might be kind of blue in their extremities, but they look fine. Like they're up, walking around, walking, talking, and they may have something like a Raynaud's syndrome where they actually have it's like a constriction of vessels in your hands and feet. And that is a specific disease. It's usually not painful and is not usually a sign of hypoxemia. But in anybody else, blue is not usually a good sign. And like I said, blue equals due. You don't need any more assessment. You need to move. You need to get them some help. Some of the clinical manifestations that you'll see is clubbing. Clubbing is a big one. I encourage you to look for this. It's something that happens with chronic hypoxemia. So something like congestive heart failure, congenital heart disease. That's what CHD is. So like kids who have tetralogy of Fallot or other cyanotic defects where they are chronically hypoxic. And there's really not a lot that we can, do about that hypoxemia. And the body adjusts to that. So it's very interesting. And we don't really know why this clubbing occurs, but trust me, when you see it, you'll know it. And it should cause you to ask, do I know why this patient has clubbing? Is that clear to me? You also want to think about chest wall restrictions that your patient may have. Could be things like scoliosis or kyphosis, a trauma of some sort. Maybe they had to have surgery. Maybe there was a tumor on one side and part of the lung was removed. Things like neuromuscular disease, like muscular dystrophy, myasthenia gravis, Guillain-Barré. I'm thinking of like Lou Gehrig's disease. Those things can all restrict chest wall movement, even pain. So when our patients are in pain and they don't feel like they can take a deep breath, think of abdominal surgery or chest surgery, but especially abdominal surgery. This is why medicating them adequately for pain control is so important. So we want to make sure that our patients are breathing well, and that's why we use the incentive spirometer so much post-op. You can get something called flail chest. This is where instead of the chest rising and the rising with inspiration and going down with expiration, you get almost like a seesaw, or you can even get a left-right flailing where maybe the left side is inflating and the right side's not. So it becomes paradoxical, meaning that it doesn't look the way that it's supposed to normally look. And again, the seesaw movements are the best example that I can give you. You want to do an assessment. You want to see if maybe it's, related to severe pain. Do they have dyspnea, cyanosis, hypotension, tachypnea, diminished breath sounds? And the best thing you can do is fix the underlying problem. So you can put them in a Fowler's position, give them oxygen, turn, cough, deep breathe, pain meds. But, depending on what's going on, like if you have, fractures on one side, and then you may actually need to mechanically ventilate this patient for a little while. It's hard. Chest rib fractures are so painful and can really take a while to heal. There's really not much you can do for them. You can't go in there and, fix them up. So, but the big problem with this is where you basically have, a hemothorax or a pneumothorax. And it's very odd to see. If you don't work in the ED or the ICU, it's probably unlikely that you'll see this. Pneumonia. This is infection of the lower respiratory tract. Can be caused by bacteria, viruses, fungi, protozoa, parasites. It causes inflammation in the lungs, and you get edema down in the alveoli, which sort of stiffens the lung, and it decreases lung compliance and capacity, vital capacity, your ability to breathe in, and causes hypoxemia. There's different kinds of pneumonia. There's community-acquired pneumonia, which if the patient ends up being positive for one of these bacterias or viruses, we consider those, like MRSA, we definitely consider community acquired. Or nosocomial, meaning that it happened in the hospital and that we didn't cause it, but by being in that environment, the patient is, just at higher risk. And then ventilator acquired pneumonia, and that comes from the bacteria that collect on all of the different pieces of equipment that we use when we ventilate a patient, specifically the ones that are, the endotracheal tube that's in their throat. And so there are steps that can be taken, certainly, to prevent this. So we can also get it from aspiration of secretions. So people who have swallowing issues, who maybe as they drink are actually aspirating some little bit of fluid down into their lungs, can get pneumonia. I know my son had he has a seizure disorder, and he had a major grand mal seizure at home and aspirated, and he was actually in the hospital for several days as they gave him antibiotics and other things, because he just sort of had a whiteout on his chest x-ray due to aspiration, because he was seizing, and he didn't obviously couldn't control that. Clinical manifestations of pneumonia: upper respiratory infection, fever, chills, productive cough. So if they have an upper respiratory infection, a lot of times that travels down to their lungs. I don't know about any of you, but I almost never have just an upper, like, sinus infection without it going down to my lungs. And that's probably because I have asthma, but it's a common thing. So pleural pain, dyspnea, and hemoptysis. Inspiratory crackles, rhonchi, wheezing. A lot of times you'll get tachypnea, and it can be kind of subtle, but this is where really counting that respiratory rate, especially in somebody who has, a respiratory issue, is super important. You don't just want to be like, oh, they look like they're breathing fine, their respirations are 18. You want to be like, no, I really counted and I know. And then the diagnosis is made by chest x-ray. You could do a CBC and look for elevated white blood cells. You could do sputum cultures to see what kind of junk is being coughed up, because the stuff that's here in these little sacs with a good cough will come out, and then we can actually, culture their sputum. And then based on that, we'll do antibiotics and antivirals. And probably for pneumonia, we'll start with a broad spectrum, and then once we identify our causative agent, if we can identify it, then we'll move in and give them a different antibiotic, a more specific, narrow spectrum. Bacterial obviously is treated with antibiotics. If you have viral pneumonia, there really isn't much that we can do, right? And we just do supportive care until the patient gets better. But the problem is that viral often sets the stage for a bacterial infection, right? Because now you have these air sacs that are inflamed and tissues that aren't healthy, and it's a great opportunity for bacteria to go in there and have a little party. So viral can often turn into bacterial. It's something that you need to know. Biomarkers that we look at, procalcitonin is a big one. So if your patient has a suspected infection, you'll see procalcitonin being done. C-reactive protein. C-reactive protein is an inflammatory marker. It talks about inflammation, so it could be high with appendicitis, but it could be high with pneumonia, it could be high with asthma, anything that causes inflammation. So it doesn't tell us where the inflammation is, but it does say that our body's in an inflammatory state. And both of these are produced by the liver in response to pro-inflammatory cytokines. So actually they're used in some ways. They can really be used as markers to measure the effectiveness of treatment as well. And I'm going to deviate for just a second here, but one of the experiences I have with C-reactive protein is using it to measure treatment for people who have osteomyelitis, which is bone infection or bone inflammation. And a lot of times we will give IV antibiotics until their C-reactive protein gets to a certain lower level, and then we feel comfortable sending them home on oral antibiotics. So just a thought that it can be used as a way to sort of monitor the state of the infection. Like, are we going in a better direction or are things getting worse? Pleuritis or pleurisy is incredibly painful. So the big symptom is pain. It's unilateral. It's usually abrupt, and it can be worse with movement. So, of course, things like deep breathing, coughing, can make it worse. And it's usually due to a viral infection or pneumonia. Pleuritis or pleurisy, like I said, incredibly painful, and have actually given patients opioids, which you have to be careful with, again, because we have an issue there. But giving them an anti-inflammatory is really helpful. And also giving them an antitussive or antitussant so that they don't cough, because coughing just exacerbates that pain and makes it really painful. It's not something that you see every day, but again, really, really uncomfortable. And that in and of itself can then lead to other lung problems because they don't want to deep breathe. They don't want to cough. They don't want to do incentive spirometer because it hurts. Here's our diagnostic tests. I think chest x-ray makes sense. Sputum specimens make sense. Laryngoscopy or bronchoscopy. This helps them just go in and actually look, like, what's going on in there. So they'll go down. And then also when they go down with these scopes, a lot of times they can also take a biopsy and see what's going on. Endobronchial ultrasound is, again, bronchoscopy to go down there and take a tissue sample. And then pulmonary angiography, and this can be used to go in and look at, like, the pulmonary artery or one of its branches, and can tell us about sort of the vascular system of the lungs if we think that there's a vascular problem. Thoracentesis, we talked about this a little bit in class. This can be the removal of fluid or air from the pleural space, which is helpful. Pulmonary function tests, this is where, people blow into a tube and they're measuring lung volumes and how long it takes you to get air in, how long it takes you to get air out. You can look at ABGs, really helpful. A lung biopsy, usually it's done by needle, and so they go from the outside of the chest, between the ribs, into the lung, take a little piece of tissue for analysis or culture. This sometimes will be done if we see things like little nodes in there or calcifications, other things where we're kind of like, what is that? Is that scar tissue? Is that tumor? Is that TB? What is it? And then you can also do what's called a VQ scan, ventilation perfusion lung scan, and it evaluates blood flow to the lungs, and again determines sort of patency of the airways and looks at abnormalities in ventilation. So lots of things that we can do with lungs. ABGs you are well aware of, and then pulse oximetry, which is used regularly now. And it's done differently for different ages. When you get to pediatrics, you'll see how creative we get with O2 sats. You know, we wrap things around their toes, fingers, hide them under socks because kids like to pull these things off. But we do, you know, it's a very quick, easy way to monitor things. Don't be fooled by an odd O2 sat reading. Really check your equipment. Probes can go bad. You know, things cannot be working, and it can really read like your patient has a problem, and then you look at your patient and you're like, they look totally fine. So you always want to correlate those things together. And then, you know, I've been sitting at the desk and see all of a sudden somebody's, you know, like a baby's O2 sat will drop to 0, and you walk in the room and see the baby in the crib, you know, gooing and guying at you, and it's like, oh, it fell off or it came disconnected. So you have to think, you always have to, you know, clinical context. All right, guys, I'm going to talk about pneumothorax and then I'm going to stop this lecture. This is a huge lecture, and I'll go on and make a part 2. But pneumothorax, we talked about this actually, I think a little bit in class. And this is where in that pleural space, remember, between the line of the lungs and the chest wall lining, you know, it's not really a truly defined space, but it can be if air gets in there. So here's a great example, right? Something, let's say a broken rib, you know, pokes into the lung. And what happens is it lets outside air enter, and that squeezes the lung down, right? And the lung kind of, you know, recoils down into the you know, into its lung space and collapses, meaning that it can't fill with oxygen and breathe. And a lot of it can happen from trauma. It could happen even from instrumentation, like maybe we're putting in a central line and the physician's working up here on the patient, but nicks the top of the lung as they're putting in this line. That can cause a pneumothorax. It can happen spontaneously, which is kind of weird. You can have these things called blebs, and I think I talked about this a little bit. We often see them in tall, thin boys, which is kind of an interesting thing, but they're like these outpouchings on the lung that are like really thin little like air bubbles almost. And so when you know, when those get thin enough, they'll pop, and then that lets air in. So it's a very interesting thing that happens. 80% of spontaneous pneumothoraxes are people with emphysema. And then, like I said, chest thorax or tension pneumothorax, where air can't escape the pleural space. So air comes in from somewhere, but it gets trapped in here. But the treatment is the same. It's a chest tube. Okay, that's the end of part 1. Whew! I'll move to part 2.